Yep, another Puscast covering the first 2 weeks of December in the year 2017. References are available at edgydoc.com, where you will find links to my multimedia empire of podcasts, books, blogs, and apps. Oh my. Otherwise, let's get on to the literature, shall we? Personally, I have issues with the metric system, mostly because measurement has a visceral component to it. If you tell me it's 104 degrees out, that means more to me than the centigrade equivalent. And the proclaimers didn't say they'd walk 500 kilometers and then walk 500 kilometers more just to be the man who walked 1,000 kilometers to be there at your door. Miles work better. This is certainly true for me with body temperature. I'm a connoisseur of human body temperature, and routine listeners know that 98.6 is a number of historical interest and does not describe human body temperature in any meaningful way. I always point to the Makoviak article in JAMA from years ago. In a study in the BMJ, they used big data on 35,000 temperature measurements in a hospital. These were all outpatients and in non-infected patients, and came to some interesting conclusions. First, of course, the mean temperature is not 98.6. They found it to be 36.6, which is meaningless to me, but that's actually 97.88. They also found the usual diurnal variation, with people being a bit warmer in the afternoon. The interesting things from the study were, one, the time of year made a difference. Summer months were linked to a slightly lower body temperature, and winter months were linked to a slightly higher temperature. Also, they found that as people age, they tend to get cooler, which would contradict what most kids would say about their parents. But it falls 0.021 degrees centigrade as people old. They also found that African American women had the highest mean temperature, and as you get fatter, as your BMI goes up, your temperature goes up as well, at a rate of 0.002 for every 1 meter per kilogram squared. And interestingly, as temperature went up, so did mortality, although not greatly. So what's normal body temperature? It depends. It depends on the month, it depends on the age, it depends on the comorbidities, and it depends on the BMI. The most important thing is 98.6 don't mean squat for mean temperature. And then, of course, that begs the question is, what is a fever? Which is the important clinical characteristic, because that's when you start doing things to people. They did not address that particular issue, nor did they address the issue of the patient who says that their normal temperature is 96, so 98.6 is a fever for me. The British don't celebrate April Fools, as best I can gather, but the BMJ in December always has articles that are considered amusing. This study was a review of the medical literature on the science behind the man flu and found it to be legitimate. A review of the literature suggests that women respond better to viral antigens such as influenza and subsequently get better faster with fewer symptoms than men do. And as they suggest in their conclusion, quote, the concept of man flu as commonly defined is potentially unjust. Men may not be exaggerating symptoms, but have weaker immune responses to viral respiratory viruses, leading to greater morbidity and mortality than seen in women. There are benefits to energy conservation when ill. Lying on the couch, not getting out of bed, or receiving assistance from activities of daily living could also be evolutionary behaviors that protect against predators. End of quote. So at least to judge from this particular review of the medical literature, the man flu is the real deal. My wife has commentary on this article. Honey, what do you think?
You men are a bunch of big babies.
Thank you, hon. I guess that's why I'm usually left to my own devices when I am ill. And as we head into what is predicted to be a bad flu season, an article in The Lancet suggests that we have been underestimating the yearly number of flu deaths. Usually the estimates are between 250 and 500,000. But using EMRs to help estimate the deaths increases that to 290,000 to a high of 650,000. The rates, of course, depending upon age and geographic location. But flu kills more people every year, perhaps, than we had traditionally thought. And we could probably prevent some of these deaths with the flu vaccine. The data suggests in one study that When moms are vaccinated, their babies are less likely to be hospitalized with influenza. So add that to the decrease in stillbirth seen by flu vaccination. It protects your baby from dying in utero, and it protects your baby from getting the flu and being hospitalized after the child is born. And does the flu vaccine effectiveness wane with time? Unfortunately, yes and no. I'm answering like the psychiatrist at the end of Psycho, who, when asked if Norman had killed her sister, he responds yes and no. He's the biggest asshole psychiatrist I've ever seen. It turns out that if you compare vaccine effectiveness in the first 90 days versus the second 90 days after vaccination, that there is some decline for the H3 and the B and not so much for the H1, which is why I give my psychiatric conclusion. But it's important to note that the efficacy does not go to zero. And that's just for getting symptomatic influenza. It doesn't account for all the other downstream beneficial effects of getting vaccinated. Valganciclovir is effective against CMV, but it's also expensive and has toxicities, especially marrow toxicities. But it may beat losing your kidney. This study looked at the role of secondary prophylaxis in patients who had CMV disease and were solid organ transplants, and whether or not valganciclovir was beneficial in preventing relapse. The answer was only as long as they were on the oral therapy. But once they stopped the therapy, the CMV relapsed at the standard rates. So the conclusion from this study is that given the toxicities and costs of valganciclovir, that it probably isn't worth it for secondary prophylaxis in the majority of patients who develop CMV while they have a solid organ transplant, which is a bummer. So where did SARS come from? The human disease? Well, bats. But interestingly, they'd never been able to find the original SARS virus in bats, just related cousins. So they went to Stately Wayne Manor, and they went down into a bat cave, and they found all the SARS viruses in this bat cave. And in this single cave, it was actually in Yunnan, China, they found all the building blocks of SARS-CoV in the various and sundry bats down there. And they hypothesized that the current human disease is due to multiple recombination events with bat SARS to come up with the current human SARS. And the first patient, of course, was Alfred Pennyworth. And the take-home, of course, is don't go spelunking in China. Pertussis has been quite the pain. The current vaccine is definitely suboptimal. And babies, newborn babies, can't get the pertussis vaccine, but they are most likely to die if they should acquire it. If mom is vaccinated during her third trimester, the chance of her baby getting pertussis drops from 17% to 7%, which is pretty good. So mom should not only get the flu vaccine, mom should also get the Tdap during her pregnancy to protect her baby. It's starting to look like azithromycin might be the wonder drug that works wonders in the tropics. I talked about how a single dose of azithromycin can eradicate both active and latent yaws, Treponema pallidum subspecies pertinu, but also in a recent study in CID, a single dose is all that's required, at least in Papua New Guinea, to get rid of skin ulcers due to Haemophilus ducreyi. So at least in the tropics, azithromycin appears to be a stone that can kill two birds. The things people do meta-analyses on. This tried to ask the question, can you rule out or rule in TB on the basis of the cough? In places where there's low resources, maybe the duration or type of cough would be beneficial in deciding who should or should not be screened for tuberculosis. And they found no evidence that the duration of the cough made any difference, whether it was 1, 3, or 4 weeks. And they could not find good data to suggest that the resolution of the cough had any bearing on efficacy of treatment. And then their conclusion, quote, most high-risk individuals and household contacts with cough greater than 2 weeks do not have pulmonary TB, but we suggest screening them regardless of cough duration. Well, duh. And then they suggest that, quote, cough is common in patients with lung infections due to MAC, other non-tuberculosis mycobacteria, fungal disease, and paragonomyosis. Wow. They conclude that pulmonary infections lead to cough. Thank you. When not working for Hotels.com, Captain Obvious spends his time publishing in the journal Chest. In a cohort out of Germany and Austria, 5% of patients with community-acquired pneumonia had undiagnosed diabetes prior to admission, and over a third had prediabetes. Those with the diabetes also had a higher mortality rate in the subsequent 180 days. Given the rate of 1 in 3 with prediabetes, it would almost suggest that anybody admitted with community-acquired pneumonia should probably get, hemoglobin H1C? I think that's how diabetes is diagnosed these days. This strikes me as a good quality improvement project for a resident looking for diabetes in patients with community-acquired pneumonia. The PCR panels have certainly changed my understanding as to the etiology of community-acquired pneumonia. Now we get all these viruses on the panel, and what do they mean? Or perhaps I should say, what is their significance? Not much, at least when it comes to mortality. This study did find that influenza A and B increased mortality threefold, but if you had other comorbidities but not chronic respiratory disease, then paramyxoviruses were associated with decreased mortality. But overall, finding one of these viruses in the PCR of patients with pneumonia had little effect on mortality in patients with community-acquired pneumonia, except to reinforce the concept that influenza kills. For those of you who are diarrhea mavens, the IDSA released their guidelines on the diagnosis and treatment of diarrhea. I'll read it in more detail some night when I've run out of Ambien. Guidelines are always so dull. But unfortunately, that doesn't mean I can't ignore them. So how about traveler's diarrhea? This study was done in US and UK service members who were in Afghanistan, Djibouti, Kenya, and Honduras. If they had watery diarrhea, they were randomized to either get a single dose of azithromycin, levofloxacin, rifaximin in combination with loperamide. And the outcomes were the same in all of the above. Everyone got better at the same rates. Although rifaximin had a non-statistically significant better treatment failure. About 2% for the rifaximin and about 4% for the other agents. I'm not certain that servicemen would be considered to be typical tourists in terms of both where they go and what they eat. But it would suggest that prolonged courses of antibiotics are unnecessary for travelers' diarrhea. And if you don't give a lot of antibiotics, you're less likely to get into the complications of antibiotics, such as C. diff and resistance. Less, again, would appear to be better. An interesting potential source for ESB-producing bacteria, specifically Enterobacteriaceae, may be raw pet food. Not that you are going to eat raw pet food, but your cat does. And cats that eat raw pet food are more likely to have ESB-producing bacteria in their stool specimens. If I'm ever having a bad day at work, I'll just remember these poor bastards had to collect cat shit for 3 weeks. Sign me up. But it was the cats that ate raw pet food that had ESB-producing Enterobacteriaceae, and what's in our cats and in our dogs soon gets into us. So if you don't want to cook your cat's food, you can always at least autoclave the cat. And sometimes you should mention negative studies. Prompt antibiotics are associated with increased survival in patients who have sepsis, but not too prompt. This study looked at the efficacy of giving antibiotics in the ambulance, and it did not improve survival, regardless of illness severity, per the conclusion. The median time to antibiotics was 26 minutes, so a half an hour or so delay in getting antibiotics probably makes no difference. So what do you do with a borderline quantiferon? A borderline quantiferon is one where the results are between 0.2 and 0.99. Well, retest them. And if you do that within the next 4 weeks, at least half will actually be negative. And none of them will develop tuberculosis. In those that had a range above 0.99, 0.9% developed TB in the subsequent 2 years. So it can happen, but a really low positive or false positive or intermediate quantiferon should just be retested. Diagnosing TB still remains a total pain in the neck. 3 other tuberculosis-related things of interest. Another study that demonstrates that diabetes is a risk for tuberculosis, and the poorer the glucose control, the more likely you are to develop tuberculosis. I saw an article in my feeds that one of the downsides of NAFTA has been an increase in obesity in Mexico. I assume with that will come diabetes, and with that should come an increase in tuberculosis south of the border. An interesting study in the test tube that showed that penicillin kills MTB when it's combined with avibactam. So I'd keep penicillin and a beta-lactamase inhibitor in the back of my mind if I had an MDR-TB or someone who, for some reason, such as pregnancy, as they note in this article, who cannot take standard drugs. And finally, the giant pouch rat is booming in Africa. It is indeed a giant rat. It grows up to 3 feet long, but it can be trained to smell tuberculosis. And there have been prior studies that I've talked about on this podcast about the use of the giant pouched rat as a screening mechanism for TB. And it's also used for mine detection in Cambodia and Colombia. And the nice thing about the giant pouched rat is that when it reaches the end of its life, you got dinner. This is an interesting question when you grow aspergillus in the sputum of patients. I've been asked over the years of patients who have non-tuberculous mycobacterial infection what to do about the isolation of aspergillus in a sputum sample. The question under the circumstances, of course, is it real or not? Or are we just seeing airway colonization in damaged airways? And this study suggested about 7% of the time, patients with non-mycobacterium tuberculosis pneumonias will go on to develop chronic pulmonary aspergillosis. And the risk factors are being old, being male, being thin, having COPD, being on steroids, and having fibrocavitary disease. So the more immunocompetent and the more damaged your lung, the more likely you were to develop chronic pulmonary aspergillus. But you can't necessarily blow off an aspergillus in the sputum of someone with, say, MAC pneumonia. And as far as antifungal prophylaxis in patients with neutropenia, what's best? Now, this study looked retrospectively at all their patients and found it didn't matter which one they gave. The outcomes were pretty much the same. But the important thing was how soon antifungal prophylaxis was started in the neutropenic. And the sooner it was started, the better the outcome. So posaconazole, voriconazole, whatever, take your choice. But do it sooner rather than later, probably as soon as the neutropenia starts. And a couple of cryptococcal pearls. There was a case report of a patient with a kidney transplant who had 2 false positive cryptococcal antigens, yet had cryptococcal meningitis. So, as always, beware the false negatives. And the other was a pair of patients who had cryptococcal disease due to Cryptococcus gattii, and they both had anti-GM-CSF, that's granulocyte macrophage colony stimulating factor, autoantibodies. So directing antibodies against various cytokines is one of those growing fields of risk for infectious diseases. I always forget the specific autoantibody out of Taiwan that was associated with development of AIDS-like infections. I always have to look it up. It's in the New England Journal of Medicine. But if you have weird opportunistic infections, AIDS-related infections in patients who don't have HIV disease, think about various and sundry autoantibody or other cytokine issues. As if I can remember all these cytokines. There are so many of them. They've almost become like evil humors as far as I'm concerned. ID used to be so much simpler. Me find bug, me kill bug, me go home. Now, me have to know immune system. Ugh. In case you missed it, I will read the abstract. Quote, we describe a hospital infestation by 2 hematophagous ectoparasites of cliff swallows that nested in the window eaves. Breaks in window seals allowed entry of swallow ticks and swallow bugs. These pests emerged in large numbers in patients' room and hallways and stairwells. 17% of the ticks fed on humans. Ew. I remember once one of my hospitals had all their windows open on the psych ward. People could not escape, but I could just imagine bats or other things going into the psych ward. Now I have to worry about bird ectoparasites as well. But there is no end to the curious ways that humans can be exposed to infectious diseases and perhaps their vectors. The ongoing problem of beta-lactam allergy, because patients don't get optimal therapy, they get second-line agents and do poorly. And most of the time, the beta-lactam allergy is BS. There's all these algorithms about doing skin tests in patients first before challenging them with a beta-lactam. I tend to just ask the patient what happened. And if they didn't have a true type 1 reaction, if they didn't die, I just give them the beta-lactam. It's a lot faster than doing skin testing. Perhaps I'm too cavalier, but someone needs to do a study comparing just doing a good history versus adding a skin test and seeing if all the time and effort of these algorithms is worth the buck. I don't think it is. And I have this bit of magical thinking that if you put the code cart outside the room, the patient never has a reaction, which is a parallel to my other bit of magical thinking that I participate in the hospital. When I have a head and neck infection patient, I always put a tracheostomy kit in the room, and it never gets used. Of course, I'm not seriously suggesting that you use magical thinking as your primary mechanism of determining whether or not a patient should get a beta-lactam for their infection, but so much of the time, the history is just a bogus reaction. And as long as they didn't have a true anaphylaxis, hives, laryngeal edema, I don't worry about giving beta-lactams. And we'll finish up by answering the question offered in the article, Increasing Evidence of Nephrotoxicity of Piperacillin, Tazobactam, and Vancomycin Combination Therapy. What is the clinician to do? Well, don't give the combination. They refer to that combination as the, quote, workhouse, unquote, regimen at many institutions. It's more the Decerabit combination in many institutions. And so often when Vanco and Pip-Tazo are given together, it's by people who don't know the difference between a burro and a burrow. The widespread use of vancomycin and Pip-Tazo is, I think, evidence that most people most of the time have no idea what the hell they're doing in the treatment of infectious diseases. It harkens back to my not infrequent rant that antibiotics should be treated like anti-chemotherapy agents and only be allowed to be prescribed by people who actually know what they're doing. What a concept. Your institution may have a microbiology that would suggest that, but most of the time in my hospitals, those aren't needed. And seriously, how often are you worried about Staph aureus and Pseudomonas at the same time? Like never? I know I exaggerate, but still, the point is Vanc Pip-Tazo is often given when it's not needed. And that brings us to the end of this Puscast, the last one for the year 2017. I'll next be back in January of 2018. So in the meantime, I would like to wish everyone a generic, non-denominational seasonal greeting. Although if they're looking for someone who wants to volunteer for the war on Christmas, I would be happy to be a general. Or even a lieutenant. Because I really realized I hate Christmas. Other than that, references are available online. And as always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you. In dictation. Goodbye. Oh, and go Vikings.